Hello everyone, this is Sadia Tanami. I'm an internal medicine PGY resident at Texas Tech University Health Science Center, Amarillo. Here I am presenting a case about heparin-induced thrombocytopenia with thrombosis. So what is this? It's actually an immunologic disorder where antibodies bind to the heparin platelet factor 4 complex and subsequent activation of the platelet release macrogranules that causes thrombosis, and also at the same time platelet consumption by these splenic macrophages lead to the thrombocytopenia. So here we are reporting a 64-year-old female with essential hypertension presented to the emergency department with progressive dyspnea at rest, orthopnea, and paroxysmal nocturnal dyspnea after being discharged home 2 weeks earlier following 3-vessel coronary artery bypass graft or cabbage surgery. Patient didn't complain of any clinical features similar like this during the discharge time. An initial evaluation in the emergency department revealed a low platelet count, elevated D-dimer, elevated BNP, and also elevated troponin. CT angiography demonstrated extensive thrombus in the right main pulmonary artery that extended into the right upper lobe artery with moderate to large size of associated pulmonary infarction in the right upper lobe. There were also small amount of thrombus seen in the right lower lobe and in the left lower lobe as well. So the patient was started on high-dose heparin infusion to treat her pulmonary embolism. However, the next day the patient developed sudden onset weakness of her left upper extremity and MRI of the brain without contrast. Here in figure 1 we can see that showing multiple right-sided cerebral. In fact, we also did the transthoracic echocardiography and esophageal echocardiography. Here in figure 2, in the transesophageal echocardiography showing right-sided multiple thrombus and large left ventricular apical thrombus. So the heparin was discontinued immediately, and the patient was started on argatroban, and the thrombocytopenia resolved within a 1 week around like 200K, and the patient later was transitioned to the apixaban 5 milligram twice daily. So heat occurs in less than 0.1 to 5% of patients who are exposed to heparin, and it depends on the patient, type of heparin, and the duration of exposure. Because patients undergoing cardiac surgery routinely receive the intraoperative heparin, so it's actually difficult to diagnose in this patient due to prevalence of non-immune mediated transient thrombocytopenia. So how we can diagnose the heparin-induced thrombocytopenia? It includes the clinical criteria like thrombocytopenia, more than 30 to 50% decrease of platelet count from baseline, features of thrombosis, timing of the decrease in platelet count following the heparin exposure, and also the low likelihood of other causes of thrombocytopenia. And lab testing include the serologic test, that is the antibodies, and the serotonin releases is the gold standard diagnosis. However, whenever we have any clinical suspicion of heparin-induced thrombocytopenia, all form of heparin exposure should be discontinued, including the heparin flush, and patients should be started on alternative anticoagulation like argatroban, bivalirudin, or danaproid. So back to our case, it is extensive arterial and venous thromboembolism is most likely due to heparin use with cardiopulmonary bypass during CABG. So it is advisable that whenever a patient present with the features of thromboembolism and a recent history of CABG, heparin-induced thrombocytopenia should be considered and ruled out before initiate heparin. Thank you.